Okay, I think everyone is okay. We can all hear you, says Prabhu on everyone's behalf. So I think if anyone has a problem, just write on the chat or try and speak, and we'll try and help. So this session is going to be, I hope, really basic, because even something like differentiating a pelvic fracture from an acetabular fracture there can be some pitfalls with that. And so we'll talk about really basic stuff. Can I suggest, if anyone has a question or anyone wants to say something or add something, just unmute yourself and start talking. That's probably the best way to do it, because I don't want to talk constantly. And the other thing to say is that we will get thrown off this after 40 minutes, which I think is enough. But if we're in the middle of something or people still have questions, then everyone can just jump back on with the same meeting code. Okay. So, so what is this? Can anyone say what is this? Is this fixation of a pelvic fracture or an acetabular fracture or both? What have we done here? These are all intraoperative images of fixation. And you can't see the fracture because obviously we've reduced it, but you can see there's metal work, quite a lot of metal. We like to put a lot of metal in, and it's being used to treat what? Does anyone have any idea? No? Anyone?
I would say acetabular fracture.
Okay, why do you say that?
Because of the kind of bird foot plate is usually used for the medial wall kind of buttress.
Okay, here, right?
Yes.
Yeah, exactly. Yeah. So that's a component of an acetabular fracture, and the massive plate spanning the whole of the ilium is also used for an acetabular fracture. So yeah, and Nick has also said that. So absolutely spot on. That's acetabular fracture fixation. But you can see how, if you hadn't seen the surgery, you might think, gosh, the hardware is over half of the pelvis. Maybe this was for a pelvic fracture. So similarly, when we see quite an extensive fracture, to differentiate, is it an acetabular fracture? Is it a pelvic fracture? Or is this one of the 15% of cases where you have an associated pelvic ring fracture and acetabular fracture? So this is Mo, I think, is that Moritz with his microphone on? No? Okay. Okay, so this is, Nick, what's this?
There's been fixation of a, looks like posterior wall acetabular fracture, perhaps.
Yes.
And there's an anterior column as a screw as well, sorry, in the, yeah.
Yeah, so the screw is in the posterior column. Okay?
Posterior column, sorry, yeah.
So remember the posterior column, the ischium where you sit, your seat, that's posterior column. And so hardware that ends up here is looking like it's a column screw because it's long and thin. That's posterior column. Anterior column runs from the symphysis, right, which is what you feel at the front. Okay, and on over here we've got an anterior column screw and a posterior column screw, and with the oblique views they look either almost perpendicular or almost parallel. Okay, so that's what we're talking about. Acetabular fractures go into the socket of the, might sound really obvious, but if you think like pelvis and you're thinking, gosh, I don't know, is this an acetabular fracture or not? Look at the socket, look at the dome. And so one thing that you shouldn't really say when you're describing these, you know, in the professional MDT or when you're talking to colleagues, is that the acetabular fracture goes into the dome. Okay, it's like you're saying the acetabular fracture is an acetabular fracture, right? It's something just to recognize for yourself whilst all, you know, if you're trying to differentiate the two. But don't describe that as a feature of acetabular fractures. It's a feature of all acetabular fractures. Whereas the pelvic ring you're looking for disruption of the ring, most commonly with disruption at or near the sacroiliac joint, or at the symphysis, or ramus fractures. Yeah. Any questions about that? I think that's really straightforward. Okay, so you can see the anterior column is a really extensive structure. It covers most of the ilium. Does anyone know what we call the part of the pelvis that's still bone colored here? That's next to the sacroiliac joint. It doesn't form part of the anterior column or posterior column, but we do refer to it when we're describing fractures, when we're planning surgery, when we're carrying out surgery. What do we call that part of the pelvis? The part that's still bone colored. This part. That part there. What's that?
Is it the alar?
Yeah, it's the alar. Hang on, let me try and stop this. Oh. I want to stop it at the back. Okay, so the alar is actually part of the sacrum. So okay, so the alar, the sacral alar, is the part of the sacrum that forms the sacroiliac joint. This here is ilium, but ilium is like this massive bone that's half the pelvis, more than half the pelvis, most of the pelvis. And so this part here is ilium that forms part of sacroiliac joint. We call it the constant fragment. And when we're describing fractures that are partial articular or complete articular in any part of the body, there's got to be some reference where you describe the displacement according to where the fracture has moved from. And so the axial skeleton and the constant fragment form the reference for describing acetabular fractures and their displacement, right? Constant fragment, really important concept in acetabular fractures. And it helps us to define what a partial articular acetabular fracture is, which is the majority, and a complete articular fracture where the whole of the acetabulum is separated from the rest of the skeleton. That's a particular type of acetabular fracture, an associated both column fracture. So the ilium is this massive, the whole of the green anterior column is the ilium and the constant fragment. Oh, apart from this part down here, what's this part down here where you go up to the symphysis? What's that called? The hemipelvis is basically the ilium, the pubis, and the ischium. And the posterior column is mostly ischium. Yeah, ischial spine, ischial tuberosity. And you can see the posterior column is much less extensive structure than the anterior column. Okay. And I thought it's quite good to look at real cases and to have some time to go over them and describe them accurately. Okay, so what bone is broken here?
The ilium.
Yes, Nick and Ahmed, you're right, the ilium. So does this look like a pelvic ring fracture or an acetabular fracture, or is it difficult to say?
Hard to say at the moment, but
okay.
It probably extends down.
Right, so it probably extends down. So you have seen already the top of the ilium, okay, but what you don't know is, does this fracture go into the sacroiliac joint? You don't know if there's a fracture in the sacrum. You don't know if there's a fracture extending into the acetabulum. So spot on, it's a fracture of the ilium, and we have to see what happens next. And this is often the first sequence that you see. Okay, so have we got any more information yet?
It's not in the SI joint.
It's not in the SI joint. but we're seeing just the very top of the SI joint at the top of S1. We're not yet at the mid segment of S1, right? You can just see the top of the vertebral body there. You're not seeing, and you're seeing, you know, this space here and here means you're not even at the midsection yet. My pants. Somebody's got their microphone on. Thank you. Okay, so, all right, so what's that? What are we seeing now? You can turn your microphone on to speak, but then you have to turn it off again.
So we've got more SI joint with sacroalar coming in.
Yes, exactly. So you can see all of S1. You can see the mid section of S1. You can see both SI joints really well. And you can see that the fracture is still only in the ilium. Okay, what about now?
The SIJs are still congruent.
Yes. Okay, they're congruent and they're normal. So congruent can mean injured. You can have an injury through the sacroiliac joint resulting in congruent widening of the sacroiliac joint. So you can say, yes, the sacroiliac joints are congruent and there are no signs of injury. So what subtle signs of injury can we see sometimes? Sometimes it's not very clear. There's something very subtle around the sacroiliac joint that indicates an injury. What could that be? Widening, yes. Sanesh, you can see that the joint is, you know, there's asymmetry. So you see widening on one side compared to the other. That's not the case here. Another thing you sometimes see is gas, a tiny locule of gas in the sacroiliac joint. That's a sign of injury. That's something we often see where there's an occult sacroiliac injury. So we see this tiny bit of gas, but the joint looks otherwise fine. And then we screen it under anesthetic at the start of surgery and it's unstable. So that's one thing. Another thing you sometimes see is flakes of bone here or here. So those are all signs of sacroiliac joint injury. What about...
Homa,
yes.
just to interrupt on that point, with the gas, does that indicate there's a bowel injury as well?
No.
Or can you have it in the absence?
No, you don't see the gas. I've never seen a bowel injury in association with gas in the sacroiliac joint. They're two very different things. So if you have a bowel injury, you'll see gas, you know, outside the bones, outside the joint somewhere. You may not, okay, you can have an occult bowel injury without seeing gas. It's something that you need, the trauma surgeons have a very high index of suspicion for. So gas in the sacroiliac joint is a sign of sacroiliac joint injury. Okay. All right, so what about the fact the patient's in the CT scan? What does that do to the sacroiliac joints? Look at the shape of the gantry of the CT scanner. Can that mask a sacroiliac joint injury? What do we think? Why do we do X-ray? So if there's no binder on, yes. Go on, Prabhu, have you got a microphone? Can you speak?
Yes.
Yeah, so what does, tell us about occult sacroiliac joint injury and the CT scanner.
So the top of the scan in which the patient lies kinds of enfolds the pelvis, masking the injuries. So when we make the patient lie down on a flat top, it will unmask any sacroiliac injury.
Right, and so that's right. We say X-ray out of binder, but actually sometimes a patient's had a CT scan, hasn't had an X-ray. There's no binder on in the CT scan, but we still need to get a plain X-ray, not in the CT scan, because we've seen cases where there's an occult anterior-posterior compression type injury with an unstable sacroiliac joint. And when we get a plain X-ray, you can see widening of the symphysis. To see a sacroiliac joint disruption on a plain X-ray isn't always straightforward. So that's why we look very carefully at the symphysis. That usually gives you the answer. Okay, so sticking with this scan, as we go down. Okay, where's Nick? He was telling me about whether this is an acetabular or a pelvic fracture. What do you think, Nick?
It's involving the anterior column. I think if we go down, it should enter the acetabular.
Okay.
If we go further down.
Okay, but you can see why.
I mean, there's some anterior SI widening on the right side. As
Okay,
well.
so we can get caught out with the shape of the sacroiliac. Is typically. You also see that that this cortex here, the thickness of the cortex here is quite different, right? It looks different from here, as if the whole thing has rotated slightly. Yeah, could everyone see that?
Mm-hmm.
So that can be positional, because it's not lying, completely straight, or it can be a sign of injury. But you can see how this could also be a massive crescent fracture. Okay, massive crescent fracture, part of an LC2 type injury so if you see ramus fractures at the front, then this is a lateral compression type 2 injury. Okay, so the big question is, does it go into the socket of the hip joint? That's the big question. Okay, what do we think? It's an acetabular fracture, right?
Yeah.
Yeah, as we suspected. So you can see there the anterior column is disrupted. Okay, there's a name for this part of the fracture. Does anyone know what we call this?
Root of the ramus.
Root of ramus, exactly. And what does root of ramus mean? Is it a feature of acetabular fractures or pelvic ring fractures?
Pelvic ring fractures.
Exactly. So a root of ramus fracture runs into the acetabulum, but is a feature of a pelvic ring fracture. And we'll see it more clearly actually here. So this is the coronal section. And so that looks like a ramus fracture, right? Doesn't even look like root of ramus. Looks like this is the same patient. And you can see that the fracture is right, actually extends into the acetabulum with a root of ramus fracture. It's not something significant for the description of this acetabular fracture. Okay, so going back to this, what kind of acetabular fracture is it? There are many kinds of acetabular fracture, and the first thing to define is it a simple or associated type? Is there one fracture line or more than one fracture line? What do we think? Is it a simple fracture with one fracture line, or is it a associated fracture pattern with more than one fracture line? You can toss a coin.
I would say, although there's some comminution, it's a simple fracture, one fracture line.
Yeah. Okay, so I can see as we go down, there's one fracture line here. Yep, and it runs down the ilium. Keep following this fracture line. Runs down the ilium, and then there's another one that appears, isn't there? Yeah.
Yeah.
But this main one is running down. Yeah. And then there's another one that appears here, I think. So I don't think this is a simple fracture pattern. I think this is maybe clearer if you look at both. So one good thing is something that the spinal surgeons do a lot of on our system. You can put two sequences up side by side and look at them together, and you can see where one fracture line is in relation to the shape of the pelvis from a different orientation. And so that's a really useful thing to do to get your head around it. but oh, can you see? Okay, there. I think that's probably the clearest.
Mhm.
You know, there's one fracture line here. There's another fracture line here. Yeah, and it's maybe clearer looking on this view than looking on the axial, but I can see it on the axial because I'm used to looking at, you know, looking at fractures from like imagining in my mind what it looks like in sort of in 3 dimensions. But you can get a clearer idea if you look at both sequences together. Okay, so if we go back to the axial, this fracture line runs through the anterior column and the acetabulum, the socket of the acetabulum. And so with a complex fracture pattern, there's a particular type that's a complete separation of the acetabulum from the axial skeleton. It's a complex fracture pattern, and defining it has certain characteristics. It's a sort of beast all of its own. It's a very common fracture pattern. It's something we see a lot of, and it's a distinct entity, different from any other acetabular fracture. And that is the associated both column fracture, or ABC. So, so in my mind, and I think most pelvic surgeons, when they see a complex fracture, they're thinking, is this associated both column or is it something else? Because the way we approach it surgically, and in this era of managing patients conservatively, that's quite important, because the associated both column has certain features that make it very different. So how are we going to know if this fracture is separated from the constant fragment or not? Can anyone suggest a scheme?
Sorry, can I ask you a question before you go ahead?
Of course.
What's the significance of the constant fragment?
What's the significance of it?
Yeah.
Yeah, the significance of it.
From an injury identification and management point of view.
Okay, good question. Good question. The significance is that, in fact, let me skip forwards and show you another picture. Okay, so this is an associated both column fracture, sort of drawn out schematically. And can you see my cursor moving around?
Yeah.
Yeah. Okay, so the constant fragment here, in many cases, in fact, in every case apart from this one, there's some continuity with part of the acetabulum. Okay, so when you're referencing the broken parts and trying to reconstruct everything anatomically, you have part of the acetabulum to reference from. And it's usually pretty obvious which that part is, right? But with an associated both column fracture, everything, the fracture lines separate the acetabulum from the rest of the skeleton. And the significance of that is twofold. Firstly, you typically get a feature called secondary congruence, where the whole of the acetabulum migrates, usually medially. And the shape of it, the shape of the socket around the femoral head is not too bad, right? It's broken, but if it heals up, everything will be, the mechanics of the muscles and the position of the acetabulum will all be different, but the socket and the function of the hip joint may not be that bad. And so secondary congruence can be associated with reasonable function, not always. And so it's only really become of relevance in this era where we're trying to manage patients conservatively. Anatomical reconstruction is associated in the literature with the best outcomes. So secondary congruence, that's one feature of an associated both column fracture. Another feature of it is that if you're aiming to reconstruct anatomically, your fixation needs to extend to the constant fragment. There's very little point fixing all of this and then leaving it where it was, to really create a situation where which is associated with, likely to be associated with good function, you need to reference it back to where it should be, the constant fragment. And so by differentiating an associated both column fracture from the other fractures, it's helpful for prognosis and for management planning and for surgical planning. So Nesh, does that answer your question?
Yes, thanks.
Oh yes, Prabhu has said something in the chat about a Spur sign. Prabhu, tell us about the Spur sign.
It's seen in associated both column fractures on the Jude views.
Yes, yes, it is. And what does it represent?
It represents that the acetabulum is free from the pelvic ring.
Okay, so it's basically this spike here of ilium that is left behind, sticking out like a sore thumb, and the rest of this typically medializes so that those are the elements of an ABC fracture, and there's your Spur sign. Okay, so that bit of the ilium is still where it should be, and everything else has moved. And you typically see it. This is an obturator oblique view, but you sometimes see it on an AP pelvis. Okay. Okay, so that's an associated both column fracture. And how do we find it? So the way I look at it is to okay, this is constant here, right? So if you follow this down, still constant, keep following it. Here it is. Here it is, here it is, here it is. If you can follow it down into the acetabulum and it's not separated by a fracture line, then it's a different type of fracture. Does anyone know what kind of fracture it's likely to be, with a complex fracture pattern going through both columns? But
anterior column, posterior hemitransverse.
Yeah, exactly. Right. And so the features of those are they're more likely to show incongruence because you have something still attached to the skeleton and the rest of the acetabulum is pissed off somewhere else. So, so you're more likely to have incongruence. They're more often found in the older age group, but not always. And they're more difficult to reconstruct, more often likely to need surgery. I mean, I think all of these need surgery in an ideal world. Okay, so we follow this down, follow it, follow it, follow it, follow it, follow it. And it's still looking, so this is where the ilium becomes quite narrow, just above the acetabulum. It still looks like it's going to form part of the acetabulum. And there, see it? Separating, just above the dome. Yeah, does everyone see that? So that makes this an associated both column fracture, as well as the fact that the acetabulum has very good secondary congruence. So you see awful displacement up here, but actually the whole of the socket, if you doesn't look bad, right? Doesn't look particularly incongruent. Okay, so that's an associated both column fracture. Okay, whose classification is this?
Jude Latournal.
Yes, yes. And so, you know, it's very dry when it's presented like this, but the purpose is it helps with surgical planning. And the elementary types have a single fracture line, posterior wall, posterior column, anterior wall, anterior column, and then there's one. Can everyone see at the top row on the right hand side? There's an elementary elementary pattern that, with a single fracture line that passes through both columns. Can everyone see that? What's that called? There's a name for that.
Transverse.
Yeah, that's a transverse fracture pattern. And what about transverse fractures? Are they easy, difficult, good thing to have, bad thing to have? Compared to, you know, out of all acetabular fractures, if I'm a pelvic surgeon, do I want to have a patient with a transverse fracture pattern or not really? Anyone have any thoughts about that?
I imagine it must be quite hard to control that fracture.
You're absolutely spot on, Alex. It's a simple fracture pattern with one fracture line, but the whole of the lower limb and the whole of the ischium and everything is all attached. And so when it's displaced, it is an absolute bastard to reduce. And I find it easiest to reduce them from the back because you have such a large, easily accessible landing strip to put your reduction tools onto. You can put a shunt pin in the ischium, you can put a young bluff, you can put various, you know, reduction forceps on this massive posterior column that's right in front of you. Whereas anteriorly, it's much more tricky. You end up trying to do plate-assisted reduction, trying to put a reduction, you know, reduction forceps down a deep, dark hole through your anterior approach. It's much more challenging. So with a transverse fracture where the maximal displacement is anterior, that's a difficult thing because the force you need to put through it to reduce a fracture is tremendous, and it's not easy. So whereas with a fracture that's with more fracture lines, you do a bit at a time, and there are a number of strategies you can use, and reliably you can achieve a reduction usually in quite a straightforward way. Okay, so the associated types, there's from left to right, posterior column posterior wall, transverse posterior wall, T-type. So what are the features of a T-type fracture? How will we know that it's a T-type fracture? It's basically, as you look down the CT scan, you see that the inferior ramus is broken and there's a fracture line passing. So watch out for that. And you see that with this angulation you get between the anterior and posterior columns, you see it when you look at the inferior ramus, it becomes really obvious. And so that is a warning sign on the CT scan of the alignment that exists between the columns. Okay, and then the last two are the ones we've talked about, anterior column posterior hemitransverse, where the constant fragment forms part of the acetabulum, right? And then associated both column, which is a complete articular fracture. Has anyone got any questions about that? So look, we're going to get thrown off this Zoom call. So I propose we end it here because I was going to talk about pelvic fractures as well, but I've bored on about acetabular fractures for quite a long time.
Very quickly, Homa, are there any that have a high association with vascular or neurological injury? Specific patterns.
That's more to do with the violence of the injury. So high energy injuries, you know, truck versus man, train versus man or woman, fall from 10 stories. You know, that those very high energy injuries are the ones that we more often see nerve injuries, vascular injuries with. It can be any fracture pattern, to be honest. So the high energy injuries tend to be more smashed up bones. So the ABC and the anterior column posterior hemitransverse. But it's a feature of the violence of the injury rather than where the fracture lines are.
Okay, thanks.
Thanks. It's always useful to recap these because even after revising, even for the exam, it's so difficult to retain it.
Yeah,